Hello everyone and welcome back to my YouTube channel. So today's topic of the video is about important questions of biopharmaceutics and pharmacokinetics, that is in your B Pharmacy third year 6th semester. From unit number 1 you have to study about the kinetics of protein binding. So you have to know that there are two types of protein binding first of all. One is plasma protein binding, one is tissue protein binding. Plasma protein binding is reversible, weak, competitive, lesser toxic, and reduces the volume of distribution. It is very essential to know the relationship between the volume of distribution and protein binding. But tissue binding is irreversible, it is strong, it is non-competitive, it increases the toxicity, and it also increases the apparent volume of distribution, VD. So you have to remember this sequence, and this is what you call the relation as well between PD and the VD, that is protein binding and volume of distribution. There are majorly four types of protein: albumin, globulin, acid glycoprotein, and lipoprotein. Albumin is basically further having four sites: warfarin site, warfarin binding site, diazepam binding site, digitoxin binding site, and tamoxifen binding site. Tamoxifen is an anti-cancer drug. Digitoxin is a cardiac glycoside. Warfarin is an anticoagulant, and diazepam is a benzodiazepine, which is used as a sedative, hypnotic, and an anxiolytic as well. Globulin. Speaking about globulin, they have basically five types of globulin: alpha 1, alpha 2, beta 1, beta 2, and gamma. In gamma, basically the binding is of antigens. In beta 2, the binding is of carotenoids. Beta 1, the binding is of the transferrin. Alpha 1, vitamin B12. Alpha 2, all fat soluble vitamins, that is A, D, E, K. Lipoprotein are of four types: HDL, LDL, VLDL, and chylomicrons. VLDL stands for very low density lipoprotein, LDL stands for low density lipoprotein, HDL stands for high density lipoprotein. HDL is also called as good cholesterol because it engulfs the actual fat, and it is actually essential to have a good HDL level and a low LDL level. Next, we have something called as absorption of drugs from non-oral extravascular routes. So basically, absorption is not just from oral route. There are other routes as well, like rectal. We have suppositories, rectal suppositories, vaginal. We have vaginal bogies for urinary infection. Then we have urethral. Urethral, mainly bogies are given via urethral route. In vaginal, we mainly give the pessaries. Pessaries. Then we have parenteral route, otic route, nasal route, and ophthalmic route. So you have to remember this thing, that otic route is basically via your ear, nasal is via your nose, and ophthalmic is in your through your eyes. In parenteral further we have a lot of many classification: IV, IM, subcutaneous, intradermal, intraarteriolar, intraarticular. So you have to remember a few of them. Intrathecal, and you have to remember the degree at which it is given. Like intramuscular is given at around 90 degree, subcutaneous is given at around 30 degree, intradermal is given around 15 degrees. So you have to remember IV is mainly 45 or so. So you have to remember the absorption of drugs via non-oral routes and the advantages and disadvantages. Also, there's a special route called topical route, which is the transdermal route, wherein you just apply ointments or a transdermal patch and see the absorption. More majorly, all of them surpass the first pass metabolism, which is very important concept that you have to remember. That is degradation of a drug or inactivation of a drug due to conversion into metabolites in the liver. This is called as pre-systemic metabolism. So before the action is actually seen, the activity diminishes. That is what is pre-systemic metabolism. In unit 2, you have to study about the metabolic pathways. There are two pathways of biotransformation, phase 1 and phase 2. In phase 1, we have oxidation, reduction, hydrolysis, cyclization, decyclization. In phase 2, we majorly have glucuronidation, conjugative phase, or a functionalization phase, wherein we add it is a synthetic phase. But phase 1 is a functionalization phase, wherein we add a functional group, that is the carboxyl group, to make it more polar. But here we add an endogenous substance so that its water solubility increases even much more. Glucuronidation, glutathione, glycine, acetylation, methylation, sulfation. These are some of the phase 2 reactions. Also, we have two types of enzymes, that is microsomal and non-microsomal. Microsomal are basically inducible and they are responsible for phase 1 reaction, all phase 1. In phase 2, I'm sorry, in phase 2, it just covers the glucuronidation. In non-microsomal, they are non-inducible. Phase 2 majorly, except glucuronidation, it covers all the phase 2 reactions. Then there's a need to remember the some terms like autoinduction, enzyme induction, and enzyme inhibition. So just remember that whenever you coin the term enzyme induction, that means there is going to be an increase in activity of the cytochrome enzymes. These cytochrome enzymes metabolizes a drug, and then this metabolized drug is not pharmacologically active. So it decreases the bioavailability. Similarly, contradictory, there is enzyme inhibition, wherein the cytochrome enzymes are decreased, the level is decreased, and the bioavailability increases. So just remember enzyme induction and enzyme inhibition. And then there is some term called as autoinduction, wherein it self-induces the metabolism of a drug. Next is bioavailability and bioequivalence. So from the name only you can make out what exactly it means. Bioavailability, that means amount of drug available in your biological fluid, that is your blood. Amount of drug available in your biological fluid. And its scientific pharmacological definition is rate and extent at which the fraction of drug gets absorbed in the systemic circulation. The rate and extent at which the fraction of drug is absorbed in the systemic circulation. While in bioequivalence, we just correlate the suspension and the solution form, or the solid dosage form and a liquid dosage form. We compare. It is a comparative tool. It is a comparative study. Also in bioavailability, you need to remember the two types, absolute and relative. Absolute and relative. Next, we have in vivo, in vitro correlation. So whenever we perform certain new exercises, parameters like dissolution. So in vitro dissolution is possible, but then we give certain conditions like 37 degrees Celsius, so that there is proper condition maintained, and this we relate with the in vivo dissolution. We carry out this in a test tube, in 6 tubes in vitro, but then we correlate it with the in vivo data, that is inside the body. In vivo means inside the body, in vitro means outside the body. Next, we have the unit number 3, wherein you have to study about the pharmacokinetic compartment models. There are many models, that is catenary model, mammillary model, and then you have one compartment, two compartment, multi compartment. Also, then you have one compartment open model, one compartment closed model. In open model, again you might have IV infusion, IV bolus, first order absorption, second order, zero order absorption. Always remember that elimination is first order. It can never be zero, it can never be half, or it can never be 2. It is always first order. So just remember that. In compartment modeling, you have to study whether there is a central compartment, and then to it there is another compartment, or there is a central compartment and there are few other peripheral compartments like this. So in this compartment there is a center and others are periphery, but if you go to see in this model, there is a series, there is a series of compartments. So just remember the compartment models as well, and remember few terms with respect to this, that is the elimination half-life, the clearance rate, the volume of distribution, the plasma drug concentration of a drug, the actual concentration of the drug. Then you have to remember the area under curve parameters, that is the pharmacokinetic and pharmacodynamic. So this is a bell-shaped curve. This phase is called as the lag phase, wherein there is, whenever you consume a medicine, it takes a certain time to be from the site of administration to the systemic circulation for it to reach. So at the point at which it actually reaches is called as the absorption phase. Then it reaches a certain point wherein there is absorption is equal to elimination. Then there is a post absorption, there is a decline, and finally there is a elimination. But there are few terms and few parameters that you have to study, that is the pharmacokinetic and pharmacodynamic parameters. Remember that AUC, that is area under curve, Cmax and Tmax, these are three different parameters pharmacokinetic. Other pharmacodynamic parameters, we have intensity of action, onset of action, duration of action, subtherapeutic level, therapeutic index, therapeutic range, maximum safe concentration, minimum effective concentration. So whenever you take a drug, there is some amount of drug which is minimum required for that activity to occur. That is what we call as minimum effective concentration. Maximum safe concentration or minimum toxic concentration is the point at after which there is toxic level. Subtherapeutic level is just below the therapeutic level, wherein it will not show the therapeutic activity, but it may begin to show, it may begin to initiate or elucidate. Therapeutic index is the ratio of the LD50 to ED50, that is the lethal dose upon the effective dose. Next we have intensity of action. What is the intensity? See, what is the Cmax? What is the Tmax? That is the time required to reach the peak plasma concentration. What is the onset of action? What is the duration? How long it is acting? So that you have to remember. And compartment modeling and bioavailability, both are very important and essential concepts that one has to remember. So please focus on that. In unit number 4, we have steady state concentration, that is the CSS. Maintaining a steady state concentration is very essential, and there are various parameters that non-linear kinetics shows, like absorption, distribution, metabolism, excretion. And basically there is two terms, absorption and disposition. In disposition we have distribution and elimination. In elimination we further have metabolism and excretion. So this chart, just remember, multi-compartment models aren't that important, so you can skip that. Next we have Michaelis-Menten equation. The dose regime is usually determined by Vmax into S upon Km plus S. This is the Michaelis-Menten constant. This is very important. Wherein S is the concentration, Km is the Michaelis-Menten constant, V is the rate and or the velocity. There are various terms like line-Weaver-Burk plot, wherein you just have to inverse. It is a reciprocal of Michaelis-Menten. So line-Weaver-Burk plot also you remember. Just remember that capacity limited, non-linear, mixed order, saturation, these all are terms for the same non-linear kinetics. So they could be asked either capacity limited, non-linear, mixed order or saturation. So just remember that this is what is the non-linearity concept based on. There are various parameters that are used for the Michaelis-Menten method. You have to remember those tests. Also, whenever you determine a drug concentration, there are pharmacological methods. There are urinary excretion data, acute pharmacological response, toxicological studies, plasma concentration. So remember, these are the few evaluation or the concentration determining parameters. And Michaelis-Menten constant is very important. So you have to study about that. So that's all for today's video. I hope you enjoyed it. If you like the video, kindly share, subscribe, and if you have any doubts, drop in the comment section. I hope I'll be able to solve them. Thank you so much, everyone.